Hello, everybody. We're going to go through a few minutes here of a review for the head trauma and TBI SOP in our protocol book. We will be referencing pages 50 through 51 of the protocol book, so if you want to have that out and available while we're going through this, it'll especially help those of you who can't read the text on the screen, such as myself. A few of the learning outcomes here. Obviously, we'll hit on some terminology. I really want to hit hard on you guys understanding the purpose behind the initial trauma care component of the SOP. We'll talk a little bit about signs, symptoms of intracranial pressure, and more importantly, understanding the difference between a concussion and other traumatic brain injuries. And at the end of the day, make sure that we can understand the significant force that it takes to create a basilar skull fracture and suspect many of the underlying conditions that are going to go along with that. I have access to a whole bunch of information, obviously through the paramedic program, so I did use the paramedic textbooks to source a lot of the information that is discussed in here. And I do have a brief handout for you guys. I'm going to ask that you take it in increments. You can work together as a group, and I'll have you pause during different sections of the presentation just to do it. It's going to take you no more than just a couple minutes. So first and foremost, let's go ahead and pause the video here. You're going to complete the pre-quiz, and as soon as everybody's done with it, go ahead and hit the resume button. Okay, welcome back. Now that the pre-quiz is done, let's go ahead and see what we're going to learn. So getting started, looking at the initial trauma care and the level 1 criteria at the very top there, the yellow section that's highlighted. I think a lot of us clearly understand the indications for transport to a level 1 trauma. And in the upper right corner there, you see in black, GCS 13 or less is time sensitive. But then right below that in the highlighted section, it talks about a motor GCS less than 6. And at the end of the day, that's really what we're looking at. So although the overall GCS does play into our treatment and our transport destinations, anytime we have a trauma patient with a motor GCS less than 6, anything less than perfect, that would be an indication for transport to a level 1 trauma center. Some of the other things on there are kind of obvious, right? Penetrating injury to the head, skull fractures, respiratory distress. Now, respiratory distress alone obviously would not be appropriate, but if we do believe that the respiratory distress is secondary to increasing intracranial pressure, herniation of the brainstem, something like that, then of course we'd be going to that level 1. And then any SpO2 less than 90%, again, associated with an underlying traumatic brain injury of sorts. Okay, so then understanding a little bit about the intracranial pressure. Within the cranial vault, you'll see that the brain matter occupies the greatest majority of space there, right? About 80% of the cranial vault is occupied by brain matter, the cerebrum, the cerebellum, the brainstem. We do have blood volume that comes in second at 12% there, and that is just all the blood volume circulating within the vasculature. And then the cerebral spinal fluid is going to be the last thing, and that's going to be in there at 8%. Now, what we need to understand is obviously the skull, the cranium is fixed, right? That doesn't expand. It's all hardened bone. So when we do have an increase in something within the cranial vault, it either causes pressure or displacement. And if you think about it, brain matter does not increase, right? It's relatively fixed at any given point in time. The cerebral spinal fluid, again, is also relatively fixed. We don't necessarily produce any less or more of it. We can't quickly absorb it. So when we do have a pressure issue, more than likely it's going to be related to blood, right? And that blood is going to either increase perfusion to the brain, or if in the case of an aneurysm or a bleed, it's going to leak out into other portions of the cranial vault, and it's going to apply pressure. That pressure then, what it does is it actually forces some of the CSF out of the cranial vault. And then as it really progresses and gets worse, it starts to apply pressure on the brain matter. And that's when we start to see a lot of changes in that neurologic function. So carbon dioxide and intracranial pressure, what's the relationship there? And as you can see, it's kind of a cyclical thing, right? It's a relationship where as one thing happens, the next thing progresses, and then eventually we wind up right back at the beginning, and it's just a perpetuating cycle where it gets worse and worse. So a rise in carbon dioxide results in increasing intracranial pressure, right? That's the simplest thing to understand. Effective ventilations are critical for closed head injuries. So what that means is if we're not ventilating our patients effectively and we're allowing retention of carbon dioxide, we're going to have increases in ICP. And this is even absent of a head injury. Anytime we have rises in carbon dioxide, we are at risk for increasing intracranial pressure. And we have to really be cognizant of that. Our end tidal CO2 target is 35 to 40. And this is where we really start to get confused in some cases. People think that we need to be hyperventilating our patients, and that is not the case. As a matter of fact, do not hyperventilate patients with head injuries. The only time that we should even consider hyperventilating is if we think that they're herniating. And we'll talk a little bit more about that in a minute. But really, our end tidal goal is 35 to 40. Now, that is on the lower side of normal, right? Normal range being 35 to 45. Our focus here, 35 to 40. And the reason being is we want to maintain end tidal CO2 levels that are sustainable for life, right? It helps maintain that balance. But by maintaining slightly lower end tidal CO2 rates, it will cause a slight reduction in overall blood flow, so that we're hopefully not going to cause that additional blood to increase the ICP. So I'm moving on down and looking at the initial trauma care for the traumatic brain injury. A spinal motion restriction if indicated. And that's really something that has to be considered, right? When do we want to use spinal motion restriction? And, we've heard some back and forth about it. We went from immobilizing everybody, putting collars on everybody, to nobody whatsoever. And now there's been a little bit of a retraction and saying, well, maybe you should be doing it, and a lot of uncertainty. So the best thing we can do here, understand the facts and utilize that knowledge to make the best appropriate decision for your patient. So it is virtually impossible to immobilize the spine. There's a simple statement there. Virtually impossible. With the stuff that we have, we don't truly have full immobilization capability. And really what we end up doing when we apply a C-collar, when we put a patient on a longboard, is it's a gentle reminder for them and for us that, hey, hold still, don't move. Even a properly applied C-collar does not actually prevent any type of motion. All it is it's meant to serve as a reminder of the underlying condition and to try to stay still. And in some cases, we know that even a long spine board or a cervical collar can create new injuries or make injuries worse. So again, pay attention to the facts on the slide here. Factor that into your decisions as to whether or not you're going to actually immobilize. So back to the initial trauma care then. SpO2 and end tidal CO2 monitoring, absolutely critical. Even if you have a patient that you suspect just had a mild concussion, right? If you're transporting them, have them on that side stream nasal cannula and be monitoring the end tidal CO2. Managing uncontrolled hemorrhage is obviously something to consider, but really, when are we going to have uncontrolled hemorrhage? We could have a laceration to the scalp. Those do bleed a lot. They are gnarly. There's no denying that. But it's never actually something that is going to cause any type of true hemorrhage. Our big focus has to be on maintaining that cerebral perfusion pressure. So the takeaway from that is, even with penetrating abdominal injuries and everything else where we talk about permissive hypotension, if we have a multi-system trauma and a head injury is included in that, there is no permissive hypotension whatsoever. Our target systolic pressure is 110, and it is 110 no matter what. And at the end of the day, even if we are considering permissive hypotension, but we're not perfusing the brain, then if we're able to save the patient's life, we're not saving their quality of life, right? They're never going to have any type of restoration of their original neuro capacity, and they're just going to live as a vegetable more than likely for the rest of their life. We're going to go ahead and treat seizures, nausea as appropriate. Obviously with head injuries, and especially when ICP is involved, seizures are a real risk. So consider that, including with management of the airway as necessary. And then check blood glucose levels. One of the things to think about too is if we do have any bleeding from the ears or the nose, consider doing an AccuCheck with the blood sample that's coming from there. Typically, if cerebral spinal fluid is included within that blood, we're going to have a much higher blood concentration, much higher glucose level than we would from a traditional finger stick. Did you know, due to the larger cranial volume relative to the intracranial contents, young children can become hypovolemic as a result of intracranial hemorrhage? This was actually kind of a neat fact that honestly I had never even thought about. With adults, the brain matter occupies a large enough space within the cranial vault that even with some type of subdural or epidural bleed, we're not going to ever hemorrhage, right? It would never be enough to put us into a hypovolemic shock. With young children, that's actually not the case. The brain matter is small enough, underdeveloped enough that we can actually see them hemorrhage. They can go into a hypovolemic state just based on a intracerebral bleed of some sort. So let's pause the video here, do a quick knowledge check, complete section 2 of the handout, and then as soon as you're done, resume. Okay, welcome back. Moving on then, and we'll review the answers at the very tail end here. So now we're going to go down to the neuro exam piece and look at that. Neuro exams, one of the things is that nobody's ever really been taught how to do a really good comprehensive neuro exam. We talk about them in medic school, we've done some different things, but what I think back to is when I went to dive school, that's where I was really taught how to do a neuro exam. That's where we're really assessing every single one of the major nerves and determining whether or not there's any deficits. It would be great to be able to do that in the back of the ambulance with every possible head injury patient. The challenge, though, is that typically when we are dealing with a head injury, we're also dealing with a lot of other stuff. It's a noisy environment. There's a lot of things going on, and it makes it difficult to do that full comprehensive neuro exam. So do some of the basics. Obviously, your routine alert and oriented questions for mental status. Consider seeing if you can do a BFAST exam. BFAST doesn't just have to be for stroke. It would be a great indicator for head injuries. Evaluate things like short-term memory. When our patients do start with the repetitive questioning, that's going to be indicative of, again, some type of head injury. More often than not, it's going to be a concussion. And continuously reassess that Glasgow Coma score. Looking back at pupils, though, super important. Looking at whether or not they're dilated, whether or not they're sluggish, are they equal or unequal? Being able to record and note any trends in pupillary changes is going to be super indicative of whether or not they have a developing intracerebral bleed of some sort. Section 3 then at the very bottom, talking about restraining or sedating. So obviously a combative patient, secondary to a head injury, is going to pose a significant threat to themselves, more so than anything else. Simply using physical restraints is not going to be helpful. If we have an underlying traumatic injury, we want to minimize movement, right? And even if we do have a head injury and we think that that is the only injury, we know that with any head injury, we have to consider the potential for spinal cord injury as well. So go ahead and be aggressive here. Utilize your chemical restraints and sedate as necessary for the patient's protection. Looking now at basilar skull fractures. So obvious deformities and stuff like that are going to be something that kind of stick out to us, right? But a lot of times it's going to be some of those linear fractures that aren't going to be picked up on. And even in a lot of cases, the basilar skull fractures. So looking at Lefort here, Lefort 1, 2, and 3, these are things where with a Lefort 1, we may see broken teeth, right? We may have obviously a broken nose or trauma to the face, but it may not be super obvious what's going on. What we have to recognize is when these Lefort fractures exist, there's a high likelihood for CSF to leak, high likelihood for bacteria to get into the cranial vault, and these are going to be some pretty significant long-term issues. So even just utilizing mechanism of injury to recognize the potential for the skull fractures here is enough to fly them out to the level 1. The intracranial bleeds then. So two primary being the epidural and subdural. We also have the intracerebral, which could be grouped into that subdural. Here's the things to understand. With both epidural and intracerebral, typically we're going to see a rapid onset with those. With the epidural and the intracerebral both usually being sourced from an artery. So because they're arterial bleeds, we're going to start to see those things sneak up pretty quick. We'll start to see those neurodeficits, complaints of headaches if they're conscious, and things that we should be able to pick up on. The subdural bleeds are going to be the slow or the difficult ones, right? When it is truly just a basic subdural bleed, it's a relatively slow onset. And you'll see that there's a lot of space that we can start to fill here. And in addition to that, because it's usually related to small venous ruptures, the bleeding is a lot slower. And this is the type of thing where you have that elderly patient on a blood thinner, they fall and they hit their head, no loss of consciousness, they say that they're fine, they refuse transport to the hospital, and then they don't make it through the night, right? Those are always what we're concerned about. And understanding that these are very slow bleeds with a lot of additional space to fill, we need to make sure that we're informing our patients, hey, there's a chance for a bleed here. It's not going to present itself right now. We strongly recommend you go to the hospital, get that CT scan, and let's just rule it out. Now we look at diffuse injuries. So, we just talked about where we had physical trauma to the brain, including contusions or even bleeding. A diffuse injury, though, is nerve-related only, and there isn't really much, if any, physical damage to the brain. And this is what happens when we have our concussions. So a concussion is a chemical disruption, but it is not really a physical disruption to the brain. And it's caused by the stretching, tearing, or shearing of nerve fibers. So what ends up happening is when we have this concussion, you have that rapid movement there, and you have that underlying nerve damage that occurs at the axons. And when that occurs, we have that loss of consciousness, and then of course short-term or long-term memory loss to go along with it. Different levels of concussions based on these diffuse injuries, but something that is generally relatively treatable, and there is no long-term deficits. There is a lot of study, obviously, on repeated concussions that are providing or causing damage to similar areas of the brain. But an isolated concussion in and of itself should not have any long-term neurodeficits. How do we manage a concussion? Obviously, you've got a history that we can run through. And looking at that, as we ask those yes or no questions, really what that's trying to do is help us to identify the potential long-term consequences of the concussion. None of it guides our treatment in the pre-hospital environment, though. We do need to be careful where we're at sporting events, up to and including even something like motocross, right? If we have that loss of consciousness, we need to recommend that they're pulled from the game. A mild concussion could just be a quick stinger, right? They're out for a few seconds, they wake up, sit out for 5 minutes, and they're ready to get back to the game. I think the sports trainers, even the coaches, are really well versed on these things now. They are super cautious, and we need to recommend the same. And even though the concussion itself is not life-threatening, we have to understand that it could be associated with other underlying injuries. And the chances of a healthy high school athlete having a bleed of some sort is relatively low, but not impossible. So again, a reason to be overly cautious. So go ahead and stop here, do another quick knowledge check, complete the section 3 of the handout, and when you're done, go ahead and hit resume. All right, as we're wrapping this up there, let's go ahead and hit the summary. So big takeaways from this. Effective respiratory management is essential to managing a head injury. We want that end-tidal CO2 to be 35 to 40. However, that does not mean that we're going to hyperventilate. Hypo and hyperventilation both negatively impact that cerebral perfusion. We need to maintain our target end-tidal CO2 and ensure a ventilatory rate sufficient to meet those demands. Permissive hypotension is not okay, ever, when we have a closed head injury. We're managing and we're targeting those higher systolic pressures of at least 110. Concussions are typically not associated with an anatomic injury. It is a diffuse injury, it's a chemical injury or chemical disruption to the brain, does not typically have any long-term physical impacts. However, we have to use it as a mechanism of injury that could suggest the risk for an underlying physical injury, and play it safe. Do not allow athletes or anybody else to re-enter play until they've been assessed at the hospital. Subdural hematomas have a slow onset, may be difficult to detect. Those are the biggest threats to our elderly patients or anybody on a blood thinner for that matter. And then sedation of a non-compliant head injury patient may be super beneficial to their outcome. Be aggressive with it. If we have to administer those sedatives, that's okay. The downside to the sedatives is that now we have a difficult time assessing GCS, right? It's not reliable any longer, but at the same time, allowing the patient to be combative and flail around is going to cause further potential injury. So a quick result, or a quick look at the answers for the quiz. Number one, what is a consequence of hypoventilating a patient with a head injury? The answer being cerebral vasodilation, resulting in an increase of cerebral blood flow, causing an increase in ICP. So hypoventilating means that we're going to allow for vasodilation, additional blood flow into the brain. And although that sounds good in theory, it also increases the overall content within the cranial cavity, which increases that ICP. Conversely, if we were to hyperventilate, it would cause a decrease in cerebral blood flow due to the vasoconstriction. Number two, what is the target end-tidal CO2 value for a patient with a head injury? The answer is B, 35 to 40. C, spinal motion restriction is indicated for all injury patients, and that is false. Only if it's indicated should we do it, but doing it overtly cautious just for the sake of doing it is not appropriate. As with anything that we do, there are downsides, there are potential consequences. So we don't want to provide these interventions unless we believe it's truly going to provide an inherent benefit to our patient. Number four, when treating a patient with a closed head injury, permissive hypotension is acceptable in the presence of a multisystem trauma. And again, that is false. We want to maintain those higher target systolic blood pressures of at least 110. And number five, one difference between young children and adults as it relates to head injuries is that young children may become hypovolemic due to an intracranial bleed, right? That the relative amount of space within the cranial vault is enough to allow them to actually hemorrhage and go into a hypovolemic state. Section 2 then, knowledge check. Why is end-tidal CO2 or capnography monitoring so important in patients with a head injury? Answer being that hypercarbia causes that vasodilation, which worsens cerebral ischemia and the intracranial pressure. So we need to monitor using end-tidal CO2, and if they are not breathing fast enough on their own to maintain those appropriate end-tidal rates, consider intubation and controlling those ventilatory efforts individually. Number two, which of the following interventions could be most advantageous when managing an unconscious patient with a closed head injury? The answer is A, drug-assisted intubation with end-tidal CO2 monitoring for the reasons we just discussed. And number three, you are assessing a 16-year-old male on the football field. The patient temporarily lost consciousness following helmet-to-helmet contact and is presenting with confusion. He obeys all commands. The trauma exam is unremarkable. Vitals are 148/86, pulse of 108, respirations are 20, is 98% in room air, glucose of 103. Does this patient meet criteria for transport to a level 1 trauma center? And the answer is no. Even with the loss of consciousness there is no underlying indication for level 1 transport. Certainly evaluation at the hospital, they're going to do follow-up CT scans and neuro exams, but there's nothing here that says this patient needs to be flown out. And finally, section 3. In the absence of alcohol or other depressant, what do sluggish pupils suggest in the presence of a possible head injury? And that's going to be that hypoxemia, right? Anytime that we have generalized ischemia, lack of oxygen flow to the brain, one of the big things that we'll start to see is those sluggish pupil responses. Number two, which type of head injury presents with a slow onset and signs and symptoms that may be difficult to detect? And that's going to be that subdural hematoma or subdural hemorrhage. And finally, true or false. A concussion typically does not involve physical anatomic injury to the brain. And the answer there is true. Those diffuse injuries are more chemical related than they are anything else. So I hope this quick review was helpful to you, and hope it helps you to provide the best quality care to your patients in the future. Thanks for listening. Have a great day.